Hello everyone, I'm Dr. Park Cha Riom. Today I'd like to discuss an important topic. Many of you have probably heard that achieving a clean cut is important during VPT. I'm sure many of you have heard this before, and it truly is important. Let me show you what a clean cut actually looks like. Of course, achieving a clean cut is our ideal goal. However, understanding what constitutes a clean cut and what does not is extremely important, because if you perform VPT based only on tactile sensation, without directly visualizing the area, you're likely to experience many more failures. This patient is a 53-year-old male. He presented with sensitivity, pain, and discomfort while chewing. On the right side, the intraoral photograph revealed a visible crack line. It also appeared that a previously placed restoration had dislodged. In this case, a substantial amount of tooth structure had already been lost. For several reasons, I felt that crown would be necessary to protect the tooth. Let me walk you through the case as we watch the video. The initial preparation had already been completed. Around the existing restoration on tooth number 46, crack lines were visible, and I determined that VPT followed by crown restoration would be advantageous. Let's open the access cavity. Let's speed things up a little. The restoration comes off quite easily. We've now reached the level of the canal orifice. Let's take a closer look. This is tooth number 47. It appears to be a ZOE-based restoration. After removing the existing restoration, given the depth of the lesion, I felt that VPT would be beneficial for this patient. The patient had symptoms, and there was also a crack present. Using a number 4 round burr at high speed, I create the initial outline of the cavity preparation. We're busy removing the existing restoration and excavating the caries. The direct view gives us a much clearer visualization. Do you see it? This is the crack line I'm referring to. Now let's look at tooth number 47. You can see this mass of pulp tissue here. You shouldn't stop at this stage. The canal orifice should be clearly visible. You need to extend the preparation a little deeper. Using a number 8 round burr, carefully refine the cavity and remove any irregularities from the chamber. It already looks much cleaner than before. But take a closer look. Does it really look clean? To me, it still looks quite messy. Since I already have the number 8 low-speed round burr in hand, and because we're treating both number 46 and number 47 today, I'm also refining the access cavity in tooth number 46, making sure there are no overhanging shelves or residual structures covering the chamber. I'm also checking for any secondary caries, evaluating whether the dentin is sound or soft and compromised. This is tooth number 46. Does this look clean to you? Rather than seeing a clearly defined canal orifice, the pulp appears to have been amputated somewhat irregularly. I believe we need to extend the preparation slightly deeper. I'll switch to a high-speed round burr. Personally, I often use a number 1 size burr for this step. It looks much better than before, doesn't it? I want the orifice to appear as a distinct point. I'd like to extend slightly deeper in this area. Using mirror-assisted visualization, I position the high-speed round burr precisely and perform a clean amputation around the canal area so that the canal orifice converges into a clearly defined single point. This is an important moment. Although I thought I had created a sufficiently divergent access cavity, there are still pulp remnants trapped within the cavity. This is primary root dentin, and these are residual pulp tissues attached to the chamber walls. Would you be able to accurately identify and remove these remnants with the naked eye? The MB and ML canals are connected through an isthmus. Rather than leaving it in this configuration, I prefer to continue until the orifice converges into a distinct point by extending the preparation slightly deeper. Now, it looks much better than before. The ML canal appears to be adequately prepped. I'd like to refine the MB canal a little further. I want this configuration to converge into a clearly defined point. There is still some tissue remaining. Now I think we're getting close. This is the DB canal. I'll lightly refine it as well. That's sufficient for tooth number 46. Let's move back to tooth number 47. The pulp fragments attached to the chamber walls need to be meticulously and cleanly removed. We're not grinding the tissue away, we're cutting it. Some clinicians advocate using diamond round burrs for this procedure, but in my opinion, carbide burrs are much more effective for cutting and removing pulp tissue. The MB and ML canals now appear to converge into distinct points. The field is much cleaner than before. After irrigating with sodium hypochlorite, I'm applying MTA. This is tooth number 47 and this is tooth number 46. The material can be gently condensed using a cotton pellet. Now let's compare the results. We'll compare the condition immediately after access opening with the condition just before restoration. Let's start with tooth number 47. This was the appearance after the initial access opening. The pulp tissue had not yet been cleanly amputated. Even with nothing more than a number 8 round burr, you can achieve a much cleaner result, as you can clearly see here. However, we still need to extend the preparation slightly deeper. This is the condition after using the number 8 round burr. Notice these white structures attached around the chamber walls. These are flesh-like remnants of pulp tissue. Let's go ahead and remove them. This is a critical step, so let's watch it at normal speed. I need to clearly visualize exactly where I'm working. You can see the pulp tissue being caught by the rotational force of the carbide round burr and being peeled away from the chamber walls. The residual pulp attached to the walls is also being removed. You need to create a more divergent access cavity than you might expect. Once you've done that, let's look at the final condition before restoration. Of course, it's not absolutely perfect, but the canal orifices are much more clearly exposed than before. These are the MB and ML canals of tooth number 47, and this is the distal canal. Let's compare tooth number 46 as well. This was the initial appearance after cavity preparation. This is what it looked like. The canal orifices are not clearly visible as distinct points. Do you notice the difference when we go slightly deeper? MB, ML. Here is the DL canal and the DB canal as well. The canal orifices are now clearly visible. The pulp tissue is no longer covering the chamber floor, allowing the orifices to be clearly identified. After cleanly amputating the pulp tissue below the level of the orifices, you should apply MTA. This is the preoperative intraoral photograph. This is the condition after the initial preparation. This is after MTA placement. And this is the completed VPT case. After 1 week, the patient remained asymptomatic without any significant issues. This periapical radiograph was taken after crown try-in and final seating. Thank you for your attention.